Hello everyone, my name is Allie Harber and this is my advocacy project. The news article I chose was the October 3rd, 2025 CBS News story titled 25% of American adults with mental illness aren't receiving treatment. This clip begins with the Mental Health America statistic that 25% of adults suffering with mental illness are not receiving treatment. They then jump into an interview with Mary Gabberty, interim president and CEO of this nonprofit. She says a major positive in the system are the declining rates of youth experiencing major depression and suicidal thoughts. This is attributed to states that truly invest in mental health care. One example is New York. They have K-12 mental health education, expanded school-based mental health services, crisis care, and peer support. However, the main issue within this group is the lack of preventative care. For example, 7 million youth did not get their wellness physical in the past year, further contributing to these numbers. Within adults, she identifies two main issues as coverage and care. Coverage is the lack of affordable health insurance that creates this main barrier to treatment. Care is that access directly relies on the availability within the behavioral health workforce. Due to this, states must invest in workforce policies, increase reimbursements for providers, and make sure they have telehealth policies so people can provide that access and care throughout the whole continuum from prevention, early intervention, and treatment. They finished by sharing that 77% of adults with substance abuse disorder were not receiving treatment. This is also directly impacted by states' investment regarding access and care. The relevant policy I chose is the Community Mental Health Services Block Grant. The history of this policy begins in 1963 with the Community Mental Health Centers Act, which funded the first community-based mental health centers. Then in 1981, local community grants converted to a single Community Mental Health Services Block Grant administered by the National Institute of Mental Health. Then, in 1992, there was a Reorganization Act that created the Substance Abuse Mental Health Services Administration to oversee services and funding. This also split the policy into the Community Mental Health Services Block Grant and the Substance Abuse Prevention and Treatment Block Grant. Then, most recently, in 2022, the Restoring Hope Act reauthorized the grant through the fiscal year of 2027. This also required that 5% of funds be set aside per state for crisis care. A formula grant is yearly funding from Congress that is divided among states according to a prescribed formula. After they receive these funds, states can either run programs directly or subgrant the money to local providers. The Mental Health Block Grant is a federal funding program for community-based mental health services for adults with serious mental illness and children with serious emotional disturbances. This provides flexible funding to help fill gaps not covered by Medicaid, Medicare, or private insurance, further supporting people who are uninsured or have temporary coverage gaps. States must use funds for services that improve outcomes in recovery and must collect performance outcome data. The target populations are 1. Adults with SMI, who are persons 18 or older with a diagnosable behavioral, mental, or emotional condition substantially interfering with or limits one or more major life activities. 2. Children with SED, persons up to age 18 who have a diagnosable behavioral, mental, or emotional issue that results in a functional impairment that substantially interferes with or limits a child's role or functioning in family, school, or community activities. States must also fulfill performance requirements, which include submitting yearly plans and reports to ensure access to services and proper administrations of funds or subgrants to local providers. They must participate in monitoring or site visits, and they must create their own planning councils. The first of these councils is the Mental Health Planning Council. This focuses on mental health and bringing agencies and consumers together to guide the state's mental health plan. The second is the Behavioral Health Planning Council. This covers both mental health and substance abuse, helping plan and advise on all behavioral health services. Strength of this policy is that it provides services for vulnerable populations, such as adults with SMI or children with SED. This also fills insurance gaps, specifically funding services that Medicaid or private insurance may not cover, such as crisis care, peer support, and outreach. Another strength is the requirement of performance tracking that encourages cross-agency planning and state accountability. However, a weakness of this policy is that there are studies that show allocation no longer reflects the changing population demographic characteristics and the needs of states. Additionally, funding has not matched proper inflation rates, furthering these lack of provided resources. Additionally, lack of funding leads to staff and research shortages, which may cause facilities to increase prices to offset these costs. This furthers othering low-income clients. Another important weakness is that due to the strict budget caps, this block grant lacks the funds to scale beyond a gap-filling role instead of allowing this branch to find new or more efficient ways to support this population. Recommendations include increasing overall funding to support new programs and long-term system building beyond simply filling these existing gaps. Another recommendation is to regularly update allocation formulas to reflect current population needs, including adults with SMI and child SED prevalence, demographic changes, and actual service costs, ensuring federal funds distributed equitably and target areas with the greatest demand. Additionally, we could recalibrate the cost of service index, which updates weights of labor, rent, and other costs. This could better reflect costs, reducing staff shortages, and prevent fee increases that limit our low-income clients. Additionally, there needs to be more focus on prevention. The Substance Abuse Block Grant requires 20% of funds for primary prevention. I believe there should be a similar emphasis on the type of allocation within this block grant, knowing how important prevention is in mental health issues. Finally, my recommendations for social workers begin with representation for clients in state planning councils to advocate for SMI and SED services and implementing trauma-informed and culturally competent practices. My next role of social workers is to stay up to date on current events. Currently proposed changes are pushing for 5% of funds for early intervention under the proposed Early Minds Act. There is an additional $19 million in supplemental funding that is going to support services for homeless individuals with SMI. Social workers should also use their social justice focus to advise on plans, funding, and policy to support evidence-based, culturally responsive initiatives that address disparities and promote systemic equity. They should also provide direct client care through delivering counseling, case management, crisis intervention, and resource navigation through MHBG-funded services. Finally, they should help to build community partnerships by connecting agencies, training programs, and stakeholders to strengthen the overall behavioral health workforce. Overall, the Community Mental Health Services Block Grant plays a critical role in supporting vulnerable populations, creating accessible care, and promoting recovery. By investing in funding, workforce development, prevention, and social justice-oriented policies, social workers and other advocates can strengthen mental health services, expand further access, and ensure that more individuals receive the care that they need. Thank you all for listening to my presentation, and I would highly encourage you to research more into this policy and its implications.